So, good evening, everyone. I am Dr. Natesh Prabhu, President of Indian Medical Pharmacologists Association, a national body which represents the doctors who are specialized in pharmacology. Now, we are in the middle of a pandemic and fighting our best to stay safe from COVID 19 by staying home. During this time, there are various efforts which were put forward by expert teams of doctors to provide evidence based knowledge in the management of COVID 19. As a team of expert pharmacologists, IMPA, with the support of Docplexus, is happy to present this panel discussion on COVID 19 management from pharmacologists' perspective. Till date, as of 4:30 p.m. today, we have around 5,75,444 positive cases globally and 867 positive cases in India. The global death toll is 26,654, and the Indian death toll is 25 cases with 86 patients being discharged after recovery. The Ministry of Health and Family Welfare, ICMR, and various government bodies are doing their best to provide us best possible management guidance. But still, the panic prevails among public and various doctors. As an attempt to contribute a drop of information to the ocean, IMPA experts have come forward to share the knowledge with you all. And today, we have our panelist, namely Dr. MUR Naidu, who is the Independent Director of NATCO Pharma Hyderabad, Dr. Ezhil Arasan, who is the Managing Director of Dr. VRE Research Labs, Chennai, Dr. Bikash Medhi, the Professor of Pharmacology and Additional Medical Superintendent of the PGMR Chandigarh, Dr. Subhrojyoti Bhowmick, the Clinical Director of Academics at PRS Hospital and BKR Research Center, Kolkata. And finally, Dr. Damodaran, the Associate Clinical Development Medical Director, Novartis Hyderabad. Our speakers will be delivering a 10-minute lecture each, and finally, we'll be having a panel discussion where they will answer all your questions. You can type the questions in the comment section below, along with the speaker's name, towards whom you have directed the question. So let us start the show now. First, for the first lecture, we have Dr. Professor MUR Naidu, the patron of IMPA, who is a renowned and a senior clinical pharmacologist who has more than 35 years of teaching experience and had retired as the professor cum head of Department of Pharmacology and Therapeutics, Nizam Institute of Medical Sciences, Hyderabad, and have been the ex-dean at the same institution. He has been part of various government research projects and currently heads the NATCO's Pharma Drug Discovery and Development Team at Hyderabad. He will talk about the available drugs in the published literature which don't have any regulatory approval tag for COVID-19 and suggestions to doctors for using it in the needy patients. Now let us hear from you. Over to you, sir.
Namaskar. Actually, you should use the same thing to avoid the handshake because that is responsible to make all those problems associated with the transmission of the disease. As was told that I shall be talking on various drugs which are presently recommended under the clinical evaluation of coronavirus. I shall talk on the three aspects. One, actually drug useful in coronavirus, the drug repulsive, and third, I will talk about the corona vaccine. The coronavirus disease was first detected in China, identified as a cause of fatal pneumonia, and in the event of epidemic outbreak, a series of action has been taken by government to control the pandemic of this virus. There is urgent need to prevent the corona infection and cure the disease. However, there is no specific drug or vaccine that can prevent the coronavirus infection. Some clinical trials on new drug against coronavirus has been carried out. We need more time required to develop really very effective safe drug against pneumonia caused by coronavirus. It is very important to understand that there are no control data supporting the use of any of these drugs and their efficacy for corona infection is not well documented with full scientific evidence. Studies of various databases suggest that the drugs which are proposed to be used in the management of coronavirus, we can actually divide into three main categories. One, antiviral drug, second, the antimalarial drug, and third is antibiotic. Coming to antiviral drug, the lopinavir and ritonavir, these are anti-HIV drugs and they are quite effective in HIV infection. Actually, based on various in vitro and in vivo activity against coronavirus, a clinical trial has been conducted using a combination of lopinavir, ritonavir with interferon beta in the therapy in the hospitalized patient in Saudi Arabia. Now, the clinical application of these two drugs in corona patient also appears to be quite effective. Next is nalfinavir and bactigavir. These are anti-HIV drugs. Again, based on the function of target protein, it is suggested that these two drugs should possess ability to block the growth of coronavirus. Therefore, both the drugs may serve as a promising candidate for the drug repurposing and development against the corona infection. The third antiviral drug is remdesivir. As it is one of the most suggested drug as on today, I will be able to cover this is little more. It is a very broad spectrum antiviral prodrug with potent antiviral activity against number of viruses including coronavirus. Remdesivir have been able to advance into clinical study so quickly because of two very important reasons. Number one, it is very successful in treating the patient with Ebola and was found to be very safe in human use. The second reason is that it has large evidence of preclinical data studied on various cells and even infected animal models that indicated that it can be a very good drug for coronavirus. One study which is published very recently last month from the researcher from USA showed that this drug has significantly inhibited the replication of coronavirus in infected monkeys. It is important to know that it does not go after the virus directly. Instead, it targets the system of the virus which is responsible for replication. So it has got some additional advantage. Several randomized clinical trials are underway to evaluate the efficacy of this drug in both moderate as well as severe corona infection. It is now being tested in 5 major clinical trials that have been set up as a fast track mode, including the first case which is treated in United States where the drug was given intravenously. I think the first trial result will be expected next month. Our hope for this drug is quite high. As per the last month WHO statement, there is only one drug right now that we think may have real efficacy in coronavirus, maybe remdesivir. Coming to very important drug that is anti-malarial, chloroquine, hydroxychloroquine. Both chloroquine and hydroxychloroquine have been reported to inhibit the coronavirus in vitro, although hydroxychloroquine have shown to be little more potent as an antiviral. Use of chloroquine is included in the treatment guideline for China National Health Commission and was reported associated with reduced progression of disease and decrease the symptom of coronavirus. The primary data support this claim and have now been published. Chloroquine have been used in the treatment of corona infection. It is widely used as an antimalarial drug and as an immunomodulatory drug. It was found to inhibit the growth of coronavirus in various clinical studies. Coming to hydroxychloroquine, it is an analog of chloroquine that is widely used in the treatment of various rheumatological disorders. It has been shown to have a good antiviral activity in patients with corona infection, and with more accumulating evidences are coming up. Hydroxychloroquine appears to be a promising agent for the treatment of corona infection in combination of various drugs. Recently, it has been suggested that a single dose of 400 milligram of hydroxychloroquine or even 200 milligram can provide adequate lung tissue concentration to inhibit the coronavirus infection in the lung. Use of hydroxychloroquine may be practical, cheap, safe, and effective agent for prevention of potential lethal corona infection. It has less side effect as compared to chloroquine. One should be careful about the use of these drugs because there is a marked increase in the incidence of cardiac arrhythmia with these drugs. In pregnancy, chloroquine should be used, not hydroxychloroquine. Now, the anti-malaria have been approved by various regulatory bodies to be used in the prevention and treatment of corona infection. One must remember that these anti-malarial drugs for prevention or treatment must be used under the supervision of qualified medical practitioner only as they know about the proper use of this drug in a coronavirus because they regularly get time to time guidelines issued by their government. Remember, self-medication can lead to life-threatening situation. Now coming to the antibiotic, that is azithromycin. Azithromycin is the antibiotic plays a role in treatment of a viral infection like corona. In general, the viral infection often produce co-infections that are bacterial in nature. So the use of antibiotic in treatment with viral infection is not novel or unusual. However, the data that combined with hydroxychloroquine and azithromycin, which has been recently published from the French study, is very much doubtful because of poor designing. Now, few preliminary results have shown a synergistic effect of combination of hydroxychloroquine and azithromycin, but still we need a very good data with this combination. Coming to the use of glucocorticoids, the WHO and CDC recommend that glucocorticoid should not be used in patients with coronavirus pneumonia unless there are other indications like exacerbation of chronic obstructive pulmonary disease. Glucocorticoids should be used only when it is advised by the medical expert. Coming to repurposing of approved drug that could help in fighting corona infection. There are various drugs which are already approved by the Drug Administration for various indications. They could hold a promise in fighting corona disease. Some are already approved drugs might successfully target corona infection. Top list includes the antiviral drugs like daunorubicin or nalfermin or scripnavir, which work by targeting the proteases. Researchers also identify several candidates, including ACE inhibitor, chemotherapeutic agent, some of the painkillers, antihistaminic, and even some anti-malaria. One of the most promising candidates is rosuvastatin. It is a statin which is already taken by millions of patients around the world for lowering their cholesterol. Rosuvastatin already exhibits a very strong safety profile and is it not very expensive and already available, and probably this may be a very good drug which may come from repurposing. Repurposing these approved drugs could be fast way to get treatment to patients who otherwise have no option. Finally, something about corona vaccine. Many labs are developing vaccine in the world for corona. Recently, a new vaccine trial has been started in USA, but one has to remember, and it is recommended that testing this vaccine must try to get some clear answer about at least 3-4 questions. These 4 questions are: do people really develop immunity? What kind of immunity is developed when the vaccine is given? How do you know whether the vaccine is working? And the last and very important question is that whether these vaccines which are developed are very safe. Finally, the take-home message is: number one, chloroquine and hydroxychloroquine are now officially recommended for coronavirus. Number two, the antiviral agents are very promising, and remdesivir seems to be most promising experimental drug which is undergoing clinical trial in combination. And the third is that repurposing will soon provide at least 2 to 3 effective and the safe drug for coronavirus. Thank you very much. Namaskar.
So thank you, sir. Now I can see many questions popping up. Our speaker will answer those questions during the panel discussion. Now we have our next speaker, Dr. Ezhil Arasan, a well-known pharmacologist popularly who is known as Dr. Arasan in the pharmaceutical industry with over 3 decades of experience of pharmaceutical medicine in the clinical development, specialty product development, global product portfolio management, who is also the patron of our IMPA and the honorary president of IMA Kodabakam branch to address us now. We doctors and pharmacology and therapeutic knowledge centers are all the time bombarded with questions on the potential preventive measures over and above, which is recommended as the gold standard for prevention. Social distancing, staying at home as much as possible, and hand hygiene. Dr. Arasan will be addressing all these aspects. I welcome Dr. Arasan. Over to you, sir.
Thanks, Natesh. The next 7-8 minutes, I shall overview some of the preventive or potentially possible preventive measures over and above what the CDC and other guidelines have given us. I would also like to make a few clear disclaimer statements before I proceed further. Other than normal healthy food, there have been no specific instructions to the public or our professionals from any authenticated sources. So therefore, the suggestions or the discussions that will follow in the next few minutes actually do not replace or supersede any of the standard guidelines, okay, which are published and recommended by Ministry of Health, the Government of India, or any of its agencies. So we reiterate, we would like to reinforce that the discussions that we hold now are suggestive of possible ways to look at a healthy, proactive measure. And we do not induce or do not want to induce or to advise to prescribe, but would like the medical professionals, the pharmacologists, and other medical professionals to apply their own individual scientific judgment before taking any of our deliberations. I think this applies largely to my talk, more so, but as a patron of IMPA, I think I can say that it stands applicable to most of our discussions here. As Dr. Naidu said, we don't have a vaccine at the moment. As I deliver this talk, hygiene measures, safe distancing, self-protection against droplet exposure, and being responsible citizens are non-compromisable, whether you are considering any other measure. The key to selection of a potential agent are very important. What are the specific principles? So I have drawn up some of the key principles, right? And let me narrate those principles. Anything that you give should have absolute safety. A proven safety is of paramount importance, number one. Number two, it should have reasonable evidence that that whatever you propose has been of some use in some other viral infections or similar coronaviral infections. And or somewhat you can extrapolate a viral data to this data. This is applicable to most other viral infections. So there should be some reasonable evidence. The word reasonable evidence here that I use is very important. At the moment, you don't have the level 1 evidence that you would want to have otherwise. the randomized controlled trial, um, which could be and well powered and very well reproduced at multicentric and different places. That kind of a study at the moment you may not have, right? So it is the time. It's a testing time where you have to question, okay, evidence-based medicine is necessary, and we are not going to show away this evidence-based medicine, but then evidence-based medicine and the experience together, somewhere along the way, we need to find an optimum level. And it's like a war situation. That's where, you start judging at that point of time what the best thing to do. So therefore, we use the word reasonable evidence. So I would reiterate what I said is, first is the proven safety. So you have to be extremely clear that it's safe. Number two, reasonable evidence that it will work because it has worked in this place, it has worked in this viral infections. Therefore, looking at these mechanistics of its action, I anticipate that this would work. That's the second principle. The third important principle is the whatever that you give does not interfere with the diagnostic methods. Right? It does not interfere with your your RT-PCR assays, or with any of the antibody measures that you're going to come out with. So it doesn't interfere with the diagnostic procedures or diagnostic outcomes. Right. So this is the third principle, and the fourth important principle is, of course, availability, affordability, and ease of consumption. Right. So it should not be very cumbersome, and and should be easily, freely available, and should also be affordable. Shouldn't be prescribing or recommending something where you don't have proper evidence, and then very expensive, and then make the patient pay through the nose. So these are four key principles that we would like to insist upon. So rather than prescribing what are the things to be used, I would prescribe the principles that you need to follow. Safety, reasonable evidence, does not interfere with the diagnostic methods, and availability, affordability, ease of consumption. So these are principles that you need to remember. So therefore, scores of such recommendations are pouring out in the WhatsApp and in various media. But then if you apply these principles, you would be able to quickly come to a decision, oh, these are good and these are not that very good. So that is typically possible. There could be more possible criteria, of course. I'm not saying that I have given you a very long, exhaustive list of principles, but I think reasonably this is a starting point. And we could keep adding to these principles and perfecting the solutions. So based on the principles that we suggested earlier, there are few potential agents that can be considered. Right. While we can go on giving a long list of agents. The moment we medical pharmacologists start giving 4 or 5, I am very sure that the alternative medicine practitioners will have about another hundreds of different solutions. And India is a country with rich Ayurveda, Siddha, Unani, and the alternative various treatment measures. So each one will start coming out with so many potential solutions. So then it all becomes the government's huge responsibility. In other words, we professionals have to step into understanding those clutter. But the point is that one can have a long list of agents and limitless. It's very important that we apply some principles to filter them out, right? So I'm going to restrict my discussions very quickly to 3 agents, just as an example I'm taking. The reason I restrict my talk to few agents is not to mean that the ones that I'm going to talk are the best, or because it's greater than the others for some reasons, etc., etc. But you are every day bombarded in the WhatsApp, Facebook, and LinkedIn, and more medias every day. So therefore, I want to give a flavor of how we could possibly use these examples and then apply to this principle in the C. Okay, for example, the first one that we could look at is vitamin C. In fact, vitamin C has gone out of stock. Because I'm in the pharmaceutical industry, and there are a lot of guys who keep talking to us. So vitamin C has gone out of stock completely, right? Whatever that has vitamin C, everybody has bought. It's like HCQ is going out of stock. People are buying, it's mad buying without rational. So the same way, vitamin C, whatever that contains vitamin C is going out of stock. People, it's by word of mouth, because in childhood or very early, from 1960, 1970 onwards, you have been always told that take vitamin C, you won't get cold. Yes, there is some reasonable value to it. Vitamin C has been shown to have some kind of immune, uh, you can't say it's an immune booster or something, but then the number of days of common cold, 1 day reduction in the common cold has been shown in a higher dose of vitamin C in a one or two large meta-analysis uh, taking about 15 to 20,000 patients. Some evidence is available for vitamin C, and vitamin C is economical, freely available, right, barring today's situation. There's also another good vitamin that has been shown to be of great value is vitamin D, of course. Vitamin D, there has been huge talk about vitamin D and immunity, right? But we know one thing very clear: vitamin D deficiency is very high even in patients with cardiometabolic disorders. Diabetic patients have low vitamin D levels, which is a known thing. Cardiovascular patients, most cardiac patients have low vitamin D. We do not know whether there is any causal relationship between low vitamin D to the atherosclerotic process, or is it that these two are identified as two different entities? But yes, we know vitamin D deficiency increases the susceptibility of a comorbid patient to infections, and there are evidences for that. Um, there's also very interesting evidences that vitamin D could be. It's best to give vitamin D in an optimal dose. Let us say dose up to 1,000 international units daily, rather than giving 60,000 units at one shot and then trying to jump up, your blood levels. Therefore, that kind of a cheating does not seem to be a great way of treating vitamin D deficiency. So, in vitamin D deficient patients, correcting them to normalcy may make sense. So therefore, they are pretty okay. So there is a role for vitamin D if they are vitamin D deficient, but it does not mean, very clearly, does not mean that the patients have to now go to a doctor asking for vitamin D blood levels and to see whether they are deficient or not. Because this is not the time to see vitamin D levels and then things like that. So in such case, ideally, the good thing is to go for, take a vitamin D supplementation, which could be anywhere between, 200 to 1,000 international units. It is not going to be causing any kind of a major harmful side effects, although we have to be careful about vitamin D. Hypervitaminosis is an issue. So I would not suggest, start taking 10,000 and 60,000 international units, but then I think 1,000 up to 1,000 international units, or even a little more, should be acceptable. So vitamin C and D seem to have a role, and there are good amount of evidences that they do have a role in the immunological modulating capability. They are not, immune booster is not the right word to use, but immunological modulation has been shown. There are some evidences for vitamin C and vitamin D. There are newer evidences available. Same way, probiotics. Probiotics is this book that was released by the Chinese the first university hospital. They say that I can send you the link of that book. That book says that there is a disbalance in the enteric in the enterocyte level. They clearly say there has been an intestinal microecological dysbiosis, right, and manifesting in reduction of intestinal probiotics such as lactobacillum and bifidobacterium. It's a very specific statement saying that it is the intestines of the patients with COVID had reduction in lactobacillus and bifidobacterium. It does not say that maybe proactive administration of lactobacillum or bifidobacterium uh, is going to change, but it implies it's sort of a deciphered information that possibly if you keep your gut flora reasonably populated with bifido and lactobacillus and things like that, you may possibly have some potential value. And the one thing is very clear: the viral infection, both in rotaviral infection as well as in various other viral infections, the role of probiotics have been reasonably shown to be of value. Although the level of evidence, it may not be level 1 evidence all the time. It may be level 2, but there is evidence. There are good number of randomized control studies using probiotics, and majority of probiotics are extremely safe. Of course, in patients with immunocompromised situations, one has to be careful. But the fungemia or bacteremia due to this are extremely rare over the last maybe several years, decades of usage with probiotics. So C, D, and probiotics do seem to have some kind of a protective role. We try to also look for some evidences for zinc and other minerals. Zinc does have a role to play, but we don't know exactly against this particular viral infections does the role. But in terms of the overall rotaviral acute gastroenteritis, zinc has played a role. There has been reduction in the number of days of diarrhea and the frequency of diarrhea. So possibly zinc has a role, like probiotics and vitamin C and D. So I'm just giving you a flavor of these. I'm not going to go into a full list. You can always read up and you can do lots of Google work, and then there are hundreds and thousands coming in. But one thing is very clear as far as CVD, as COVID is concerned, staying to factual information is very important. So you are very soon in a kind of situation where you may be like soldiers who are deciding on the foot. It's good to know the principles. If you remember the principles, then you take a decision. I think your decisions would not go wrong. So before I close, I'll just reiterate the principles on which you can choose. First should come to your mind is the proven safety, reasonable level of clinical evidence, does not interfere with the diagnostic procedures, and it's available, affordable, and ease of consumption. This case, I just took case in point to discuss with you on the vitamin C and D, and then the bifido and lactobacillus combination, and then zinc-based products. So this is just to give you a flavor and making you think and decide at that particular appropriate time what is a good way to promote, to offer to the patients, right? Other than the standards are the problem. This is not a racial or ethnic issue. This has got nothing to do with those kind of things. And the immediate risk is at the moment thought to be low. You have to be very clear about the facts, and therefore it's important for us to remember the principles and act accordingly. Right. I think with that, I will leave the session for discussions later on. Thank you very much, Natesh. Natesh, thank you.
Yeah. Thank you, sir, and thanks for the very elaborate talk on this very important topic. I'm sure our viewers would have got an excellent insight on vitamin C, vitamin D, and prebiotics in moderating the immunity, and those helps to act as a prophylactic measure to prevent COVID-19 infection. Dr. Arasan will be taking the questions during the panel discussion. Now, our next speaker is Dr. Bikash Medhi, who is known as a friendly professor among students of PGME in Chandigarh. He's a editor of Indian Journal of Pharmacology and the coordinator of Pharmacovigilance Center at PGMER, and he's head of Neurobehavioral Research Lab and Experimental Pharmacology Lab. He's also the board member of various government research bodies, namely the Department of Health Research under the Ministry of Health, GCP Lead Inspector and GLP Lead Inspector for the Government of India, NABH Assessor, Investigation New Drug Committee member, National Formula of India member, and he's also a member of ICMR, DST, DBT, MCI, NBE, CSIR, etc., and multiple things. He has authored around 5 books and 80 chapters and have published more than 350 research articles in various national and international journals. We are very happy to have him, and he'll be talking about the probable adverse effects of the drugs given for managing COVID-19 and the methods to report it. Over to you, sir.
Thank you, Natesh. I think what I'm going to talk about, Dr. Naidu had already talked. Then we have a talk on probiotic, vitamin C, and vitamin D also. What I'm going to talk is, it's like I'll highlight some of the issue of using hydroxychloroquine or any of this drug which we like to repurpose for COVID-19. But before that, I like to convey that whatever I'm going to talk is in my personal capacity. So I'm not representing any institute or anybody else, in my personal capacity. Now, to begin with that, when you listen to Dr. Naidu, that if you looked at last 3 months of the clinical evidence or whatever the data we have in peer-reviewed literature, so if you search, you can find that how many clinical trials have been done with how many drugs, why they have used these drugs. So if you look at the location, is number of studies have been done in Iran, then there is studies done in China, then in Spain, US, and there are also a lot of discussion on that paper has been published from Paris of the clinical trial. Now, if you see that how many medicine they have selected for this, one of the medicine they have taken is hydroxychloroquine. Second is chloroquine. Then we have the list of antiviral drugs. I also request the viewers to go through one of the 2 articles from Indian Journal of Pharmacology, where we have published therapeutic option for COVID-19. So there we actually analyzed all the data, and we commented on some of the combination of antiviral also, which found to be have been also been commented by New England Journal of Medicine, that not all antivirals may be beneficial for COVID-19, but there are limited, evidence is there, so one has to be very careful. Now, coming to that, how you give the treatment, the question here is, there are a lot of queries. If you happen to go to any of this helpline, a lot of people, they ask. So you have a case of mild COVID-19, moderate COVID-19, and also severe cases. Now, if you see some of this recommendation, that hydroxychloroquine is one can take those who are healthcare professional engaged in working with COVID-19 patient. So this is in terms of prophylaxis. Then you look at the dose, what dose you have selected. The dose is given is 400 milligram twice daily, then weekly till 7 weeks. Then second one is those people who are high risk with in a family members, they are positive. So they have been given 400 milligram twice daily, then weekly till 3 weeks. Now, in case of a mild, because you have to see the age group, so you do not need any the treatment. But in case of a moderate and severe, we have again, suitable treatment is hydroxychloroquine at a particular dose, 400 milligram BD. Then, 400 milligram once daily for almost 4 days. Similarly, it is also been, a lot of studies says that you also give a supplementation with azithromycin. Then some of the antiviral is also been promoted. So here the question is, there are a lot of studies says that do you like to use hydroxychloroquine or chloroquine? Now, if you see, when you select a drug, this is especially infection is a nasopharynx and a lung infection. Of course, there are a lot of studies that it also involved in multi-organ, like it is also proliferating GITs. There are a couple of, evidences there. But the question is there that when you like to use this drug, you need to ask as a pharmacologist that how much it is actually accumulated in lung tissue. Then you might ask the question that, do you like to prepare a drug in case of a mild disease? Or you might have a logic that please give the drug before you have a severity. That is also one logic we can debate on. Now, when you compare with the preclinical data with chloroquine and hydroxychloroquine, when you look at the experimental PKPD data on a day 1, day 2, day 5, you get the maximum concentration compared to chloroquine, it is hydroxychloroquine. That is one of the justifications. Second point may be that maybe you reposition several drugs, but before that, you need to ask that, is it dose dependent? Like if I take an example of chloroquine, that chloroquine is given, but its antiviral efficacy, you get it once you go beyond 750 milligram. So when you give a clinical dose, is it achieving the 750 milligram in the tissue level, which you extrapolate? Then only it will act as an antiviral. Now, if you look at that hydroxychloroquine compared to chloroquine, it actually have an efficacy because it changed the pH intracellular. I also request you to look at some of the paper from Indian Journal of Pharmacology where we identified that these are the drug target. Like we have a S1 terminal, S2 terminal, or and this proteases. There are several targets. So you can also think about the repurposing that is this drug is which target it is acting through. That also we can explain as a pharmacologist. Now coming to the main queries is question of hydroxychloroquine when you use prophylactically, when you use for the treatment. Now what is this ADR profile? As you know that this drug, when you look at compared to chloroquine, so hydroxychloroquine, the maximum tolerated dose is almost 1200 milligram. So then whatever dose you selected, that you are using 400 milligram BD, but this has a very peculiarity that it has a long half-life. So half-life will start from 22 days to 54 days. So that is also we need to be remember. So coming to some of this ADR profile, as my topic is that how we can monitor the particular ADR profile, those who are taking it. You just think of that one of the important point, because there are a lot of people, they might be going for a self-medication. So I'd like to caution that do not take this medicine unless the registered medical practitioner prescribe this drug. Second thing is, this drug is not recommended in children with less than 15 years. So one should not take it and it should be away from the children. Now, when you look at a pediatric profile with a stratified age group, as you know that there are a lot of comorbid conditions in elderly. And in case of is there any difference between male and female? So when you look at the ADR profile globally or Indian context, that more of this ADR profile you get it in from the database is in a female compared to the male. Now, there are a lot of data from Canada, US, France, Netherlands, and we have also data for last 10 years. So here the problem is this one has to be very careful when it is prescribed that it can cause cardiac arrhythmia. So we have to go for a monitoring that is the patient having underlying cardiac problem. So QT prolongation, it can cause there. That is why it is very important to look at. Second thing is, when you give this drug, you should be very, very particular about G6PD deficiency, because it might go to a healthcare professional. They are using prophylactically, but they do not know that whether underlying G6PD deficiency. Of course, those who are taking for rheumatoid arthritis, actually they know that whether this has been already done. But suddenly, if you give this drug to a healthcare professional, then they may not be knowing. So one has to be very, very careful about that. So ADL profile, if you see that it is affecting the blood, because most of the people are anemic, then there is a problem with gastrointestinal problem. So, and it can affect. So one of the ADR, you can think that those who are diabetic, so there is a consequence of hypoglycemia. So I'll make it the point that you should think before prescribing, that question should be asked yourself as a practitioner, that can it develop a QT prolongation? Do the person have a G6PD deficiency or other, anemia, hematological or gastrointestinal? So this is important point, but the serious issue need to be looked at, that can it cause, serious adverse event. Otherwise, all the mild, you can see the gastritis, vomiting, like the stomatitis, all this you can get that, or skin pigmentation. But here, when you talk about ADR, you need to know that what dose you are using, how long you are using. It is very short period. You are going to give it for 7 weeks for prophylactic, or maybe for 4 days in case of a treatment. But when you give it for a longer time, one has to be careful about ocular examination. That need to be done for monitoring. Now, coming to ADL profile, as you have some of this report from life-threatening condition or very minimal number in case of a mortality, but otherwise this drug is also widely used for malaria. It is also used for rheumatoid arthritis or some of the autoimmune diseases like SLE. So now coming to the main point is, in this situation, current situation, how we are going to monitor, because this is the opportunity that if we do not generate the database, so in future we will not get that information that how this drug is in general population, or those who are taking prophylactically or treatment, how it is going to behave. So that's the reason that one can be that active surveillance, or maybe you can have a registry, and as we have a system of PVPI, so they can report to the toll-free numbers or any of the ADR centers. So active reporting is very much required by physician, pharmacist, or any consumers, which can be verified later. So that is what we have to do, is that we can also indirectly find out that effectiveness, along with how tolerable of hydroxychloroquine compared to any other drug. So coming to summary, I just want to summarize that, as you know, that with the limited evidence, what I said is, so far maybe 15 trial has been done, mostly with hydroxychloroquine and chloroquine and antiviral. Of course, other drug is also included. Some are trying to repurpose, but most of the trial, they have lot of flaws you can criticize. But you have to also understand that we have a limited time. Based on the limited time and this limited evidence, that you are going to use a drug, but we are also looking at the ADR profile, and active monitoring surveillance is required for this. And that is what we need to generate, that how Indian population is going to behave when they take the drug for a particular dose, for a particular duration, and what is that question of tolerability. I think I can take the questions in the panel discussion section. Thank you very much. Thank you very much.
Yeah, so reporting the adverse events are a very important practice during this high time of signal detection, and where the critical importance of the coexisting diseases like diabetes, as CERTOL, and also the polypharmacy is associated with that. And the whole thing should be monitored strictly. And now for the next lecture, we have Dr. Subhrojyoti Bhowmick, a renowned pharmacologist from Kolkata, who has 12 years of experience in medication management and clinical research in the NABH accredited hospital. He is a NABH assessor for Hospital Accreditation Program and patient safety expert from Johns Hopkins University, USA. He is an honorary lecturer of University of Birmingham and has been a visiting fellow of patient safety at WHO Geneva. Dr. Subhrojyoti Bhowmick is helping his fellow doctors at PLS Hospital, Kolkata, to fight COVID-19 by being a team member of the COVID-19 task force. He will discuss the utility of forming the task force and the role played by task force team members, including the clinical pharmacologists, to manage the COVID-19 situation in a hospital. In his talk, he would highlight the medication, he would highlight the medical information facilitation role played by the clinical pharmacologist for the clinical colleagues during these times. Over to you, Dr. Supraja.
Thank you, Natesh. Good evening, everybody. And I would like to thank IMPA for this wonderful panel discussion and talk which they have organized in this difficult time. And I think my previous speakers, all legendary professors, have spoken about drugs, but I'm going to give you a very different angle. I am though a pharmacologist, I'm a clinical pharmacologist, but currently I am working on ground. What that means is my hospital in Peerless, Calcutta, we have a positive case of COVID-19, and I understand that on Docplexus we have doctors who are also online for this particular presentation. I have fellow clinical pharmacologists from all over the country who are probably working in different hospitals, and then I see few pharmacists as well joining. So my talk is going to be a practical experience sharing for the last 2 weeks on what could be done for by a clinical pharmacologist especially during these times. So as Dr. Natesh mentioned about that, we have to form a task force. So the question is, what is a task force? A task force is a specialized. This is a new disease, and as you could understand from our previous speakers, there is plethora of information which is coming into the clinicians, which is coming into the hospital. So what to use, what not to use. I think the most important thing is formation of a task force. What exactly is a task force? It's a specialized committee consisting of various people from various discipline, and it's not only the clinicians, but the leader of the organization should actually be heading this task force. And we should have people from the pharmacy, we should have people from the lab plays a very, very important role. And last but certainly not the least, I would say we should have people from security, from housekeeping, and in hospitals who employ clinical pharmacologists. They must be a part of this particular task force. The reason is because this is a very important group which takes on a day-to-day basis decision, because as Professor Medhi or Professor Naidu mentioned, that we have data on patient management, but we still don't know what exactly guidelines to follow. So every day, the new information is coming. You have a new guideline approved by the Ministry of Health, and you need to keep yourself updated. And the other most important thing is that everybody, all the key professionals involved in patient management, whether they are directly managing the patient, the frontline staff, when I say the frontline staff, they are our doctors, of course, they could be the medicine consultants, they could be consultants from the critical care medicine, they could be the consultants from anesthesia. They are probably the frontline staff, the junior doctors, as well as the nurses. They need to be guided on a regular basis, and this task force actually guides them on how to manage the patient. And one of the important agenda is to bridge the gap between the knowledge which exists in the current scenario. We have been seeing this happening in our hospital, and the reason is that we have to meet on a daily basis and discuss what are the loopholes which are happening. One of the major, I would like to say that one of the major important things, even if you have drugs, especially after the government released the hydroxychloroquine prophylaxis advisory, people just went haywire, and common masses started stocking, and they started buying from the pharmacy. I think this is a very important role which the pharmacologist has to play here, is to stop these sales. He has to be the guidance leader for the pharmacy and as well as for the administration. And as you are aware that this particular drug now, hydroxychloroquine, along with azithromycin, of course, was in Schedule H1, but hydroxychloroquine last week was actually upgraded to become a Schedule H1 drug. That means could not be sold without a registered medical practitioner prescription. This has to be this is an extremely important thing which has to be implemented at the ground level, and this will be done many a times. Many a times when you have a positive case coming in your hospital, the priorities shift. The priorities shift to managing the patient, to managing the communication with the government, to managing the communication with the media. Because, ladies and gentlemen, let me tell you, the media also is going to be breathing on your neck and trying to take information about the patient. So it has to be, so the task force, we must have to divide what action will be done by which group of people. And I think the clinical pharmacologist, along with the clinical pharmacy team and the clinical pharmacists, have to take upon themselves to on few of the few responsibilities. One of the responsibilities is that selling of drugs, which have been now, which have to be quote unquote are being thought to be efficacious in the management of these patients, need not be sold out from the hospital pharmacy. So that is one of the very, very important thing which needs to be taken care of. You will run out of drugs. Let me tell you, lopinavir, ritonavir, the supply chain management is going to break down, and this is going to happen because with the lockdown currently existing in the country, even if the pharmaceutical company is producing it, you will not have trucks, or you will not have dealers working. So you need to have a plan of action on how are you going to engage your dealers, and how are you going to engage your pharmacy to have these drug in stock. Because the scariest thing is that you have a patient in your hospital but you don't have drugs to treat that patient. So have a backup plan for this. Prepare for this. And one of the easiest thing, and if you look at the Ministry of Health advisory, it also tells you that you must do a mock drill, which we had done last week. Luckily we did 2 weeks before, a drill where the patient, where you have to think that there is a patient in your emergency who could be a prospective COVID-19 patient. Then how different systems are being activated. One of the most important system being the pharmacy, as well as the ICU, or the other medicine wards where the patient will be ward. You must be aware that the Ministry of Health has released that every the medical college hospitals should be divided into three basic areas. And I would say not only medical college hospitals, if there are doctors who are here who have their own nursing homes, divide your hospitals into three different areas. One area will be the COVID screening area, and will be the emergency and the flu clinic. Please close down your all routine OPDs. I would make an earnest request. Please close down your routine OPDs. Please close down your routine, communication with the doctor, with the patients. Use the telemedicine, use phones, or use WhatsApp to manage your routine patients. So this is one, will be the COVID screening area. The other one will be the COVID management area, which primarily would be the ICUs. And finally, you will have some of the patients which are the surgical patients, which will be in a non-COVID area. So this backup plan sometimes has to be, this has to be prepared, and you have to manage adequate inventory of medication for all these three areas. And I think the Department of Clinical Pharmacology plays a very, very important role in managing this kind of in the stock management. The other most important thing which I would emphasize on is the medical information role of the clinical pharmacologist. As you are aware that, we probably have named close to 10 or 12 drugs which are in different phases of development. There's a lot of questions I'm seeing which is coming on live comments on which drug is better, why we should try it, why we should not try it. I think as a specialist who knows more in terms of the safety, as our previous speakers have said, safety and the risk benefit analysis, clinical pharmacologists should issue or should develop a routine practice guideline, or I would say standard treatment guidelines, or in the other way should help to implement standard treatment guidelines issued by the government, and take care of the plethora of medical information which is blasting the medical colleagues. I'll tell you that many a times these medical colleagues are going to fall back on you. When I say medical colleagues, the frontline staff, the critical care consultant in my hospital, actually we discussed whether we should use an interleukin 6 inhibitor in our patient, and we went ahead and we used it, because though the data is very less, but if you look at the pathophysiology of the COVID-19 severe infection, our patient unfortunately is ventilated now, and you will see that the interleukin 6 inhibitor tocilizumab actually has shown an improvement in patients who are witnessing the so-called cytokine storm. This cytokine storm happens in patients of severe COVID-19. So I think you need to update your information, and you need to share that information to the task force on a daily basis. Prepare it and share it to the task force on a daily basis. Professor Medhi mentioned very beautifully about the ADR profile monitoring. I think none other than us, which we can chip in with the ADR profile. We would be able, and we should share our knowledge not only with the clinicians, but I would also say with the nurses. So I'm regularly talking to the nursing superintendents, the nursing in charges, and asking them, please note if the patients are coming down, if the patients who's on hydroxychloroquine with azithromycin, and if you're using this interleukin 6 inhibitor, what are the complications these patients, or what are the toxic events which we are noting. So we have to be, communication is the key. So we have to keep on communicating with our clinical colleagues on one end, and then with the nurses on the other end. And most important part, the pharmacy. I think pharmacy is a very, very important area which is going to manage this thing. We have to manage we have to help them keep the adequate stock. We have to help them develop the proper supply chain, talk to government officials if required. I personally have done that in the state of West Bengal, that we need these drugs, and these drugs have to be these drugs have to be stored, and this is what is our backup plan. Even if you have to go beyond your role, so don't stick to the role. I would say just expand beyond the role, because this is the pandemic. This is not a routine time. We have to go beyond that. So finally, I think, sticking to time, I will end up saying that follow the task force, because everybody is learning on a day-to-day basis. Be an important component of task force. So by assisting the clinicians, primarily the critical care clinicians, they require your help. They require your help to know about what drugs to use, what are the complications or the adverse event profile of the drugs, and also look at the drug-drug interactions. And sometimes I would say look at the clinically effective drug-drug interactions. I think being clinical pharmacologists, we are better trained, or I would say we would be able to tell that sometimes routine bookish interactions are not important. It's only the clinical interactions which we need to look at. And last but certainly not the least is extend your help at every possible end, so that we can fight this pandemic with the greatest strength. Thank you, Natesh.
Yeah, so thanks, Dr. Ashubro. I'm sure our viewers would have been greatly benefited by the talk from him. Like he has, given a various insights about how to maintain the supply chain management things, and how to have for the look for the multiple drug interactions. And we are taking questions during our panel discussions. And now we're going to our next speaker, Dr. Damodaran, pharmaceutical physician who's working with Novartis, Hyderabad, and he is well known in the pharmacological field for his PKPD discussions in the group. Being an alumni of JIPM Pondicherry, he has done various research in PKPD in the drugs, and he is currently involved in life cycle management of mature neuroscience products. Over to you, Dr. Damodaran.
Yeah, thank you, Natesh. And it's my pleasure to talk with the audience on this topic. And I'll be talking specifically on the evidence behind the use of hydroxychloroquine. Like from the previous talks and from the live comments, I can see like there are lots of interest about this particular drug. And I'll be talking like what made us to advise this drug in case of COVID management. And before going there, like I would just like to give my disclaimer. Like I'm talking on my behalf. Like the views I'm expressing here are my own and does not represent the views of my organization. And whatever information I'm using, it's available taken from the public domain. So, like when this news about this pandemic in came out and there were lots of buzz around it, like a new virus is coming up and lots of people are killed, and then all of a sudden, like people said, like hydroxychloroquine is going to be used. I think the question which popped up in most of our minds is like, how can an antimalarial drug can be used in treating a viral disease? And it seems like it's not new, at least for the scientific community. And like we know, like chloroquine is a very old drug. It's been used in treating malaria from the 1940s, but even from the 1960s, the antiviral property, unlike hydroxychloroquine malaria from 1955, and its antiviral properties also been known. So what has happened is in many in vitro studies, both chloroquine and hydroxychloroquine, they've shown the antiviral effects. And actually, like the previous coronavirus epidemic, the SARS coronavirus epidemic in the 2003, 2004, during that time, they had done a studies to show like chloroquine actually inhibits the in vitro activity of SARS coronavirus. And even in animal models, like they have shown activity against the human coronavirus, enterovirus, the Zika virus, or even the influenza virus. But based on this in vitro study and animal studies, there are lots of hopes on chloroquine as well as hydroxychloroquine to be used in viral disease. But unfortunately, in randomized controlled trials, the effect of these drugs in viral infection is not seen. Like for example, like chloroquine has been studied for treating dengue as well as in chikungunya infections, but in both these infections, it did not show any effect. And even for chronic viral infections like HIV or chronic SCV infections, these drugs were tried, but because the efficacy is not so good, they are not pursued further. And of interest is whether we could use these drugs to prevent infections. And actually, like chloroquine has been tried in a similar setting. For example, like in Singapore, they tried using chloroquine to prevent influenza infections, particularly during the epidemics. And what they found out is like a weekly dose did not prevent any influenza infections. So this is what we know before this current epidemic or the pandemic came into place. So what happened with this epidemic? So initially, like in December 2019, I think Wuhan province in China started to see like more of like unexplained pneumonias, and people are thinking like whether this could be a new virus. And by end of 2019, like they confirmed that this is a new strain of the coronavirus, and they at that time they named it as novel coronavirus or the nCoV. So lots of research was done to see like what are drugs that can be used in it. And an yearly report published in February, like early February, showed like of the panel of drugs they have tested, two drugs have shown some efficacy against the clinical isolate of the SARS coronavirus 2. That is the strain of virus which is causing the current pandemic. They used a clinical isolate in vitro studies, and they found like chloroquine and remdesivir showed in vitro efficacy. And actually, this created a lot of interest on using these drugs. And a lot of interest is focused on chloroquine because this drug has been available for a very long time. We know the safety profile of the drug much better, and it's since it's generic, like it's quite cheap to be used in larger scale. And following this initial in vitro report, many clinical trials were started in China. Like as per the data, at least 20 clinical trials were started in China to study the effect of chloroquine as well as hydroxychloroquine in the management of COVID-19. And as these clinical trials are progressing, and as previously, like Dr. MUR Naidu said and Dr. Bikash Medhi said, like we cannot wait for the results of these trials to come out to do some actions. So China has a national task force to guide the management of COVID-19. And what they did is, like, based on the yearly data from about 100 patients who are treated on chloroquine, they recommended like chloroquine can be used in the management of COVID-19 disease, and they included in the national guidelines for managing these conditions. So they include chloroquine along with many other drugs like ritonavir, ribavirin, or remdesivir. So how does this drugs actually have this antiviral effect, or how it could be used in managing COVID-19? So basically, it's because of two of their properties. One is their antiviral property, and the antiviral property is basically because both chloroquine and hydroxychloroquine, they act in a non-specific manner, and they increase the pH within the endosomes. The endosomes is a space where these viral proteins will take all the host proteins and they start synthesizing the mechanisms. And when the pH is increased in endosomes, the virus are unable to replicate. And moreover, the other mechanism proposed is like probably like chloroquine can actually glycosylate the proteins which are present on the surface of cells, particularly the ACE2 receptor and other proteins, and thereby inhibit the entry of virus within the cells. And more interestingly, apart from this direct antiviral efficacy, the other proposed mechanism action is through their immunomodulatory actions. So the immunomodulatory action of the immunomodulatory actions of chloroquine is well known, and we know like this is being used in like kind of diseases like rheumatoid arthritis, where hydroxychloroquine it has an beneficial role because of modulating the immune functions. So basically, this drug inhibits the cytokine expression and thereby reduces the inflammation. And as Shubhra was discussing, like he discussed about the cytokine release syndrome, where in severe cases the death is primarily because of the increased cytokine response. And by an immunomodulatory action, it is proposed like chloroquine or hydroxychloroquine can actually be beneficial in these patients. So considering these factors, the interest in hydroxychloroquine grew a lot, and further in vitro studies has been done. Of particular interest is like how this drug could be used in managing these patients. And when we look into the pharmacokinetics of this drug, like hydroxychloroquine has a potential to be concentrated in the tissues, particularly like the liver, lungs, kidneys, and in the blood cells. And if you take the concentration ratio between the lung tissue and the blood, it is in the range of 300 to 400. So even though the blood concentration is low, the concentration is much higher, and it is proposed like this concentration is sufficient to have certain antiviral activity. And this drug has a very long off-life because of the redistribution from the tissues back into the plasma, and then it is eliminated. So the terminal T-off of this drug is 22 days. So because of this, it is expected like if this drug is having an efficacy, even a single dose can exert the efficacy for 7 days or more. So what the data says regarding this? So in another in vitro studies, they compared the potency of chloroquine and hydroxychloroquine in inhibiting the SARS coronavirus 2. And what they found out is hydroxychloroquine is much potent than chloroquine in inhibiting this virus. Like they compared the EC50 concentration or the concentration at which like they're inhibiting 50% of this virus, and it's much lower with hydroxychloroquine. And since hydroxychloroquine is a derivative of chloroquine and has much less safety issues compared to chloroquine, hydroxychloroquine is the kind of favored agent to be used in coronavirus management. And in the same study, like where they've done the in vitro study, they kind of did a modeling analysis to see like whether if you use hydroxychloroquine, whether the concentration in the lung, which is the target organ in this case, will be sufficiently high to inhibit the virus. So in this modeling, they used different treatment regimens. One of the treatment regimens they found to be most beneficial is like they used a loading dose of 400 milligram twice daily, and followed it by 200 milligram given twice daily for the next 4 days. And with this model, they found out like the concentration of lung tissue is much higher and will be beneficial to exert its antiviral effect. And interestingly, what this modeling is also shown is that, like on day 5, we stop the drug and continue to see what will be the concentration in the lung tissue. What they found out is even on day 10, the concentration in lung tissue will be much higher than what is expected to provide an antiviral effect. And based on this particular data, it is we can even kind of infer that a single dose, single high loading dose can provide sufficient concentration in the lung tissue for its antiviral efficacy. So this is the data from in vitro and some modeling. So, but what is the data coming from clinical studies is telling us? So as I said, like there are lots of studies currently ongoing, at least 20 studies in China alone. There are lots of other studies started in Europe and the US. And all the studies are ongoing, and we'll have to wait for a few more weeks to get the results of this study. But as of now, we have like results from 2 yearly studies published. And one is a study published by the French group, which has created a lot of buzz around it. They used a combination of hydroxychloroquine in one arm and hydroxychloroquine azithromycin in another arm, and they used some control patients. But they've shown a significant decrease in the virological load in these patients on day 6. But this study has a lot of issues in the way it is conducted and the way it is reported. Like for example, the controls were from a different hospital, and we know like this is not a correct way of control or comparing patients. And most importantly, if you look into the patients who are on hydroxychloroquine, 6 patients were not included in the final analysis. The reason being like 3 patients they worsened and they were moved to ICU, and 1 patient died, and 2 patients they did not take the medication because of the adverse effect profile. So if you look at from a clinical endpoint, like we can say like 4 patients out of the 26 patients the hydroxychloroquine group worsened, whereas no patient worsened in the control group. And if you make this kind of comparison, it will appear like hydroxychloroquine is not a good drug to be used in this case. And a couple of days back, another study from China got published. This is a randomized control trial with about 15 patients on hydroxychloroquine and 15 patients on the standard of care. And this study has shown like no difference between these two groups in terms of virological conversion, that is whether they are becoming negative for the virus or not, the body temperature normalization, or the radiological changes. And these two studies shows us like studies like this, which are done with a small sample size, with less number of patients, will not give us any valid information to take. In like what you can say is like as Bikash Medhi said earlier, like the ICMR has given proper kind of guidelines for the use of hydroxychloroquine prophylaxis in healthcare workers and in like contacts of confirmed patients. And across many treatment protocols, hydroxychloroquine has been used. So to summarize, the data we have, the evidence we have, they support the use of hydroxychloroquine in management of these patients, because right now we have very limited information. So all the management is done more on an experimental basis, and because we have no other option, we are using this drug in patients who are severely ill. And particularly to note, like hydroxychloroquine is recommended only to be used in patients who are hospitalized and are ill. If there is a patient who is confirmed to be coronavirus positive and this patient is not severe, like at least the data shows like 80% of the patients, they have only mild to moderate symptoms and they don't need much of medical care. And in this patient, it does not make any sense to treat them with hydroxychloroquine, and it has to be used only in case of severely ill patients and who are hospitalized. And coming to prophylactic use, the ICMR guidelines clearly says like it is to be used only in patients or only in persons who are high risk. The first high risk group is like healthcare workers who are exposed to suspected or confirmed COVID cases or to close household contacts of confirmed cases. And apart from these 2 high-risk groups, this drug should not be used in other people mainly because of the adverse effects. Previously, sometimes these cardiac adverse severe and can lead. So we need to be very cautious when using this drug for prophylaxis. And here the role of the doctors, pharmacists, everyone comes into play. And like doctors, because we may get like patients who want to be put on hydroxychloroquine for prevention of infections, but like doctors should make it clear like this drug should not be used in all the patients. Thank you. Go to you, Natesh.
Yeah. So thanks, Dr. Damo, and for our viewers, we have done our best in this difficult situation to keep the relay so much very convenient for you, because there were some audio disturbance also. So we just apologies for that, but still, like, we're going to continue with our panel discussion. We are getting a lot of questions on this hydroxychloroquine plus others. So all the five speakers will be going live, and the questions which have been asked, I'm going to ask them again, and they'll be asking your they're going to answer your questions. So yeah. So hi sir, hi everyone. So let us go for the panel discussion now. So let us have the first question now. The first question, I think Dr. Suresh Katka, he's asking, how useful is hydroxychloroquine as a preventive drug for COVID-19? Is it advisable for each and every doctor should take it? Something like that. I think we can start with Dr. MUR, sir, being a senior person here.
Yeah, just actually, other speaker very clearly told that there is a specific guideline. The people, those who are exposed or those who are actually having contact with these people, and all the medical people, paramedical people, those who are handling these patients, there's a definite role of prophylaxis, and new guidelines clearly state that various dosage it has to be used. This is recommended by Government of India, so that has to be followed, and they have clearly mentioned who are the people they should take it.
Okay, sir. Okay. So now let us go for the second question. And is the question getting displayed, or shall I read out? I think, yeah. Dr. Arora, he's asking, what are your views on use of bioelectromagnetism in COVID-19 cases? When sun flare become low growth of influenza virus enhances, BMED produces low frequency bioelectromagnetism. I think what he's asking is that, can we suggest bioelectromagnetism or this beamer? Beamer is an instrument where I can see people go lie down to get few fixed UV rays, like, which can protect them from the diseases. This is a very non-specific question, so I think it is open for discussion. Like, which speaker want to answer this question? Anyone?
I will take this question.
Yes, sir. Please, sir.
Natesh, the answer to Dr. Arora's question is clear no.
Okay.
Clear no in the absence of any guideline, right?
Okay.
And we do not. I just have given the right on which you need to choose any alternative suggestions, right? You have to apply whether it is completely safe. Do you have reasonable evidence for showing that it will be effective? And do you have, is it interfering with the treatment? And fourth is availability, affordability, and ease of usage, right? I don't think this is available for everybody. This is available for somebody. This will create a kind of a panic for scenario where hospitals have to start running for something else. So clearly at the moment it is a no.
Okay. Okay, sir. So there is a no. So let us move on to the third question now. The third question will be on the screen. This is from Dr. Verani. A negative COVID-19 test may also mean that the person does not have active infection. But how do we ascertain that person may have had it in the past, recent past, and now he's in the convalescent phase? Dr. Bikash, I'd like to write on this.
I think provision is that you go for a repeat test within 24 hours. Then you have to also see what method they have used. Okay. There's activity. But sometimes there may be gray area. If it is negative, also there is symptom is there. It's better to keep it isolated, so that it will not be, because if it is false positive, it will infect the others. So one has to be very careful.
Okay. Okay, sir. Yeah. Thank you. Anyone else?
Yeah, I think just to add to what Professor Medhi is saying is also the IgM and the IgG concept which we have, So if the patient has got a active infection, we'll look at the IgM antibodies. and if the patient is in convalescent, then the IgG antibodies will be higher. That's what I learned from my infection control head. I'm not an infection control specialist, but that's the advantage of communication with talking to the infection control people. So that would be a bit more addition.
I think
While on this topic, there is also this kit, IgG, IgM kits that are going to come in, right? There are, in terms of scale of production, I was told that IgG, IgM based antibody detection is much easier to produce, so they can produce some millions of kits a day or something like that, and uh, the sensitivity specificity studies have to be done. But what are your take on that? Do you have any thoughts on that?
So is this a question? Direct? Yeah, sir,
Yeah,
you
to
want
you,
to say? Professor Medhi
Subro.
wants to add something. Yeah,
Ah,
Professor Medhi wants to add. Professor
yes,
Medhi, please.
yes,
I think this current stage, you need to also be careful about what method you are using, their
Right.
sensitivity. Because if you look at some of the news from Spain on US, there are a lot of kits coming which is only sensitivity is 30%. So one has to be very careful that is it the appropriate test we are doing, what stage if somebody has approved, that need to be looked at.
Okay. Okay, sir. Shubro, you want to add something in there?
No, I think regarding the kits, to answer the question about the availability of kits, as you currently understand, yes, with the lockdown being in place, India is of course looking at its own kit, which is going to be developed very soon. But the availability of kit is an issue, at least in Calcutta.
Yeah, what I like personally feel is that this these kit availability, like everything, like it's a double-edged sword. People tend to rely more upon the kits. So what happens even like when there is a false positive, so there could be a panic among them. So there is also a case.
okay. We will leave it to the experts, our SMR experts later on. Yes.
Yes, sir. Thank you. So let us move on to the next question now. Dr. Dinesh Shah, he's asking, does hydroxychloroquine plus azithromycin really useful in prophylaxis of COVID-19? Dr. Damon, like you to take the question.
Sure, Natesh. So, hydroxychloroquine plus azithromycin, definitely no, because what we are
Somebody
discussing.
needs to be muted. I think there is a backdrop noise.
Is it fine now? Yeah.
Yeah, fine. Yeah.
Yeah. Okay. Thank you. So, for prophylaxis, hydroxychloroquine plus azithromycin should not be given. The reason is the cardiac toxicity, because hydroxychloroquine is a drug which is known to increase acuity, and same with azithromycin. And if you're going to combine these two drugs, the risk of QT prolongation is going to be much higher than when both these drugs are given separately. So these two drugs should not be used together, that too in the case of a prophylaxis. Because when we mean prophylaxis, the patient is not in the hospital. Maybe for treatment, if there is some secondary bacterial infections, they could be used, but the patient will be in a hospital under medical supervision. And for hydroxychloroquine, again, what we have been discussing is the beneficial effect is questionable, but the harmful effect, that is the cardiac risk, is definite. So as of now, because we are not very sure of the beneficial effect, we are recommending it only for people who are at very high risk. That is doctors and other healthcare workers who are exposed to COVID cases. And there is another question also: can every doctor take it? If there is a physician who is not going to be exposed to COVID, like there is in other specialties who are not exposed to COVID patients, they did not take it because of the risk associated with it. So to answer this question, this combination definitely no for prophylaxis. For prophylaxis, only hydroxychloroquine. That too only for high risk group. The first high risk group is healthcare workers exposed to suspected or confirmed cases. The second high risk group is close contacts of confirmed cases. And again, the exclusion or should not be given for children less than 15 years. And even in other patients, it should be cautious.
Okay. So what a general public think is that they go crazy over this. They just go and buy this medicine. So absolute self-medication as a prophylaxis, like it is no big no. So now let us move to the next question. Dr. Sandeep Kumar is asking hydroxychloroquine or chloroquine, which is better in the treatment for COVID-19 and why? I think Dr. Medhi was like telling about this, the chloroquine and hydroxychloroquine. Sir?
So what I said is with limited data, because we have a limited time, then it is kind of an investigation. It is nothing like a, based on the current data, you say that when you compare with chloroquine and hydroxychloroquine, it is a marginal benefit when you compare with hydroxychloroquine in terms of radial profile. But you can see that over a period of time, it might change also when you get more studies. But at this current point of time, you can say that maybe you will prefer hydroxychloroquine compared to chloroquine.
Thank you. Okay, sir, thank you. So let us move to the next question now. Again, Dr. Sandeep Kumar is asking, in Wuhan, the drug chloroquine worked, and Shanghai, the hydroxychloroquine didn't work. So again, what is the comment? It's a very tricky question. Wuhan, like, yeah. Anyone?
But
Yeah,
one thing is that,
yeah.
yeah, one thing you can see that like there are a lot of reports about ethnicity. Okay, but this question what he has asked is in the same region which is around 100 kilometers from Shanghai to Wuhan, maybe 700 kilometers. So that point is not valid. So you have to look at the data ethically, how they have interpreted it. This is important point because you might say 80% efficacy, but you said patient is only 20. Okay, so you have to go for it. Both the studies, you have to see the analyze the data, then only you can comment on.
Okay, sir. Okay. Thank you.
And
Damo, you want to ask?
it is also important that, like many studies, if you see 15 studies, some studies in younger population, some are with comorbid condition. So when you give the younger population, definitely it has shows the better efficacy compared to comorbid condition. So that critically you have to evaluate that.
Okay, sir. Dr. Damodaran? Yeah.
Yes. I think the question comes from the fact like the study which from China which got published is a Shanghai study, like it's from Shanghai. And I think what they mention as Wuhan chloroquine is like the initial data which kind of prompted the National Task Force of China to include chloroquine as one of the recommended treatment options. And to make a differentiation, the initial data what the Chinese task force assess is not coming from one particular study, but it is the data, the yearly data coming from all the clinical trials or all the clinical experience that happened. And this was sometime in mid-February when they had the data from the chloroquine in about like 100 patients to guide them how they can proceed further. So even like chloroquine, what there is kind of questionable because it's a yearly data, and that data is not published for us to comment on it. But the RCT, which is done in Shanghai, where like 15 patients were on hydroxychloroquine, 15 patients were on the standard of care, did not show any difference. And again, we cannot interpret this as like hydroxychloroquine has no efficacy. We can only say like because it's a very small sample size, and even the authors they say like they need a sample size of more than 750 to validate their hypothesis like hydroxychloroquine can be beneficial or not beneficial in treating these patients. So these are like clearly hypothesis generating studies, and I think like it's too premature for us to interpret in this way. Like
Okay.
Professor Bikash Medhi was saying, like there could be like extensions and virus is constantly mutating. Like there could be some minor differences in the genomic profile of the virus which can alter the sensitivity.
Okay. So, like any of the speakers have any comments on this, of the differences?
I think important point here for general population that even if somebody is taking the medicine, he should not have a false confidence that I am protected. One has to be the basic BP standard of care. One should not have a false confidence that I am taking this. I
Yes,
will
yes.
it is very important to understand everybody. This is at this point of time.
Understood, sir. Understood. Yeah. Fine, sir. Thank you. So let us move on to the next question now. Dr. Sangeeta Sukumaran, she's asking, is there any definite therapy or medication that can cure COVID-19? Again, very tricky question. Subhro, you want to answer this? Yes, sir. Please, sir.
Yeah, I think Professor Medhi is waiting to answer this, but I'll just say as of now, there's no FDA approved drug which is a definitive therapy or medication, but we have guidelines from different bodies, and that's where we will go with. We have guidelines from ICMR, we have guidelines from Ministry of Health. In fact, if you just see a couple of days back, Russia recommended the use of lopinavir, ritonavir in the use for Russian patients. So it is very country wise, and there are certain guidelines which the professional bodies are coming out with. The Indian Society for Critical Care Medicine has come out with a guideline which has recommended hydroxychloroquine and azithromycin. So as of now, the answer is no.
Yeah, exactly what you told. I, in my talk, very clearly told that if you go to various regulatory agencies in all over the world, they are very clearly telling that the drug like hydroxychloroquine and chloroquine, they are just actually offered as a first drug for the treatment, and rest all the medicines like all antiviral drugs or antibiotics, they should be considered as a investigational drug. So I don't think presently we can level any drug which can be used and may be labeled for curing. So this is actually presently status is there. The chloroquine and hydrochloroquine is number one drug to be used. Remaining all drugs are actually presently in the status of investigational drug.
I think a question asked is there any definitive therapy? Answer is we do not know. But however, based on the limited evidence, we have repositioned several drugs. Start with hydroxychloroquine, chloroquine, all antivirals. But over a period of time, you see that you need to understand that time is changing. Today you are saying something, then after 15 days, you have a new evidence. So you have to look for every day it's become a new day for current situation. So you have to see today. But at this point of time, we have an option that in case of somebody is for a prophylaxis, we have hydroxychloroquine.
Yes.
You are absolutely correct. Even if you see the various data which is coming, even for the antiviral drug, you can find out there is a significant change in the status of various antiviral drugs. Previously, some drug was there. Now, recently, 2 or 3 days back, some other antiviral drug are coming up showing a better activity. So there is a significant change.
I think if you read our article, we have written editorial therapeutic option for COVID-19. 2 months back, we had commented that there is a unique evidence of particular antiviral combination. So this came to be true by New England Journal of Medicine. So what I want to make it a point that let's see the evidence, then only we can comment. But at this point of time, we can only limit it to some 2-3. A lot of people are trying to reposition the drug based on the in vitro. And you extrapolate the in vitro to in vivo, there may be differences, or clinical case, as you know that there could be a lot of individual variation. And also age group of the patient is very important with comorbid condition.
Yeah, at the moment it is speculative, so we should not say anything like this.
Yeah, I think the answer should be no. And I just want to add, Natesh, and to this, that if you're using any drugs which are not as per the guidelines of any society, please take an informed consent from the patient party, because we actually did that when we used ritonavir, lopinavir in our patients. So I think because these are, as Professor Naidu mentioned, that these are investigational drugs. So for medico legal purpose, if they are not as per any society guidelines or any other in international body guidelines, you must take an informed consent from your patients if they are in a position to do that, or from their legally accepted representative.
One need to be understand that when you are looking for a new indication, you want to reposition the drug, automatically you need a regulatory permission.
Okay.
So that's yeah.
Okay. So it was so like very good to get all these perspectives. I think we can move to the next question now. Dr. Sandeep Kumar is asking, what's your take on interleukin 6 treatment in the COVID, or like he's basically asking interleukin 6 or interleukin 1. Anyone on this?
Maybe
So
I
I
take it up.
yeah
So I think they are referring to the anti-IL-6, which Dr. Zuma, which Shubhra was also referring
Yeah,
to. Yeah.
yeah,
I think that is the question because probably the anti is missing there. Yeah. So again, like this is shown at least in China, like they've shown like patients with severe cytokine storm syndrome, and they've shown like it leads to clearance of the lung fields much faster when compared to like other standard of care. So based on this, I think at least the province of China is kind of I'm not sure like their regular mechanism. It looks more like our state FDAs, and they have recommended the use of tocilizumab in patients with COVID-19. Uh, Maybe others can add to this.
I think there are a couple of case series or case reports that you need to look at it.
yeah
okay.
yeah I think what Damo mentioned, I just want to reiterate that one of the issues is the cytokine storm, which results in rapid deterioration of these patients. So definitely, these are investigational drugs again, because interleukin 6 inhibitor primarily used for rheumatoid arthritis. There is no, they are, as Professor Medhi also mentioned, they are case reports and case series, so they are not definitive treatment.
Okay. So let us move to the next question now. So we have various questions coming on Docplexus and on Facebook. So our team is trying hard to uh, sort out all these questions. Is my video clear? Yeah. Sure. So Dr. Gramol is asking, how about vitamin A? Dr. Arasan, sir?
Yeah, there are evidences for vitamin A also, but yeah, you need to take a call. I mean, you can't dump the patient with everything. So let's wait for a clear-cut guidelines at the moment. I only keep mentioning about this. You know, you can keep on asking what about vitamin K also, vitamin E also. You can keep asking that. But you have to
Yeah.
go for principles. Are there any reasonable evidences for you to ask these things? And then if there are reasonable evidences, then these are preventive measures. These are not pharmacological agents typically. So you have to take a call on the principles rather than on, whether it is A, B, C, D, or something like that. So it's not that. It's on the clarity of evidences that you have, right? If you have evidences, then you are justified to do it. That's what it is. So if you are on the front line, you have to take a call. What is the evidence? And am I doing any harm? If you're not doing any harm, your evidences are good, then you have a reason to do it. So look at the principles first rather than asking questions on which agent. Right? Principles have to be clear.
Yeah. So my personal take on this, when there are not very definitive evidence, I think vitamin A, vitamin C, everything is available in our natural diet. I think people can focus on very healthy diet as of now. And
Exactly.
if they,
A healthy diet, and if you're healthy, you don't have to take anything. You are fine, right? And if you are deficient of vitamin D, which is very likely, so there is
true,
a reason for to taking that, and there are some evidences for you to have some, probiotics. These are all things that are recommended in case you are falling short, or you have a dysbiosis, or you have abdominal disturbances. You have some indications that are suggestive that you would be better off taking it. Then you can take it. Otherwise, there is no need. If you are a healthy person, you don't need to do all these things.
true, sir. True, sir.
Otherwise, you will start. If you look at WhatsApp, then you will have some 50,000 recommendations every day. So where will you go?
Yeah. Yeah.
So
True. True.
what will you do? So that's the point.
I just want to share one experience here. When this COVID-19 issue started, I had received one phone call. Suddenly, one guy, like what person told, "Sir, namaskar. I'm so and so. I just want to share one information. You take this something called as like he told something in Tamil, like it's called as like I forgot the name. He said, please recommend to everyone, please spread the message, and he randomly disconnected the call. After 2 3 days, he again gave a call, and he told, so I'm going to give you a new information. I told him very strictly, if you're going to keep passing on non-evidential information, you're going to end up in trouble. And he stopped. Just give me a call from there. So I think people like, instead of asking about this kind of an questions on nutraceuticals, they can keep on taking, as Dr. Arasan has said, if they are deficient in vitamin A or vitamin D or something, then they have to go for this supplementation. Fine. So let's move to the next question now. So, yeah, can we have the next question now, please? Yeah. Again, Dr. Gammo, he's asking, could you please share the copy of the ebook on probiotics? Request. Yeah, Dr. Arasan sir has given the link, and it will be shared post seminar. Thanks, Tramolia. Next question, please. So yeah.
The question on Riaz Ahmed has asked most ARB and ACE, right? Okay, that is a question which people most of the time ask.
Okay, sir,
Those
please, yeah.
who are already on ACI or ARB, are they going to be affected by this kind of COVID? But in fact, the European Allergy Association has given a position statement very clearly. At the moment, the evidences are not pointing out that those who are already on ACE inhibitors or ARB having a greater preponderance for any cardiovascular toxicity or biocarditis, any kind of problem. So it's very clearly said that please do not stop prescribing or do not ask the patients who are already taking ACE inhibitors or ARB, don't stop, continue to use. So it has been a very clear position statement that has come from European Cardiology Society. And so that at the moment, they say that in fact, they say the hypothetical, it's a very hypothetical situation. It's not proven, right? So this is my latest understanding.
Yeah, what you are telling is correct because no guideline recommend stopping of these two drugs. In fact, they are telling if somebody is stopping, it will be more difficult to manage the clinical conditions. So it is not advisable to stop these drugs for management of hypertension or other cardiac problem. At present, there is no actually recommendation to stop these drugs or change over to some other antihypertensive drug.
Yeah, fine, sir. Thank you, sir. So I think again, like there's repetition of question. Dr. Colonel Jayaprakash, like she's asking, please explain difference between both hydroxychloroquine and chloroquine. I think the speakers have answered in their talk, like as well as in the discussion. I think we can like go to the next question. So what's the next question like we have here in our panel? Dr. Mantri is asking, what are the adverse effects associated with COVID-19? I think the question is a bit non-specific. It should have been adverse effects associated with the drugs in COVID-19. I think which drugs, I think Dr. Medhi sir, he clearly explained about the adverse effects of drugs. Because of short of time, we're going to cut short the repeated questions. And I think we move on to the next question, please. Okay, Nitin Joshi, in the absence of symptoms, should healthcare professional staff take prophylactic medicines? As again, Dr. Damodaran clearly said. Yes, sir. Please proceed, sir. Yeah.
I think it is already answered.
Yes, already answered. Yeah, it is.
They can definitely go into the website and they can see the recommendation which is there in the website from government. It is very clearly given and they can download. Even they have mentioned the dosage. Everything is there.
Post this webinar, like we'll be sharing all those recommendations which are available on the internet to our viewers, so they can have a download from there. Yeah. So next question, please. Yeah, Dr. Chakraborty is asking. One question is remdesivir available in India? What's the dosage schedule and any precaution to be used in special population? I think we can minimize the question now, so that the speaker can see that. Yeah. Is remdesivir.
Yeah.
So hope you have seen.
As per this drug is there because lot of information and dosage is available only for the treatment of Ebola. The present it is again an investigational drug and the recommended dose which is actually started the study in United States. One patient was given it was 200 milligram intravenously 5 to 7 days. but still we are not having a very clear data about it. But the side effect, everything which has been reported, it is only in the patient with Ebola. Very recently, one of the actually company from US has started a very big clinical trial. They wanted to recruit almost about 1,000 patients into this particular trial, and they are telling that some of the data will start appearing in the April month. So we are still waiting. There is only few actually case report or clinical trials which are done using this drug, and they have shown probably this is one of the promising drug. And my talk, I already clearly told that WHO also was looking that probably this may be a very good antiviral drug for the management of coronavirus. We have to only see the data, but present dosage, what they are using is 200 milligram intravenously, 5 to 7 days.
Okay, sir. Okay, sir. Thank you.
Natesh, there was a question about nebulization. Dr. Chakravarti asked. So I think
Yeah.
it's very clear cut that meter dose inhalations are preferred than nebulization because it generates aerosol which can carry the virus, especially in case of ICU settings. So we should try and avoid nebulization of COVID-19 patients as much as possible.
Thanks, Dr. Bro. And he's asking a second question also. In cases of patients who are on chronic immunosuppressant drugs as well as inhalation corticosteroids, should the use of those to be restricted or withheld or modified? I think the team can display the question on the screen. He had he asked one more question in there. Number two question. In cases of patients who are on these chronic immunosuppressive drugs as well as inhaled corticosteroids, should the use of those be restricted, withheld, or modified?
As, as per the guideline, they recommend that one need not to worry directly about the problem, but definitely we know that people, those who are actually on immunosuppressant drug, they are more prone for various infections, secondary infection. Present guidelines say that actually all recommendation has to be followed on case to case basis, and it should be done under the guidance of a specialist. This is the present guideline, but definitely I know that there is a possibility that the patient, those who are immunosuppressant, definitely they are more prone for various other infections. But present guidelines say that it should be on the basis of recommendation from the expert only. They should change over to other drug or they should reduce. It should be
Okay.
considered only case to case basis.
Yeah.
I think,
Dr. Medhi, sir. Yeah.
I think we need to understand that nowadays define what is high risk. Like you say, if the person is more than 60 years, if the person having underlying cardiovascular or like hypertension or diabetic mellitus, they are on immunosuppression, or there is underlying chronic lung or kidney disease, they have been categorized high risk. Then you have to individually deal with that. How you going to do it?
Dr. Natesh?
Yes, sir.
Yeah, there is one question from one of our participants who is watching us from all the way from Germany, Dr.
Yeah, please answer
Shrikant.
that. Yeah.
Yeah,
Yeah.
so
Please.
yeah, I think there is experts here who can answer this. India released treatment advisories for hydroxychloroquine as prophylaxis. Probably India is one of the first countries in the world to do it. No other country is doing it. What is the rationale of recommending it as prophylaxis in complete absence of any supportive evidence? So maybe I think Professor Medhi or Professor Naidu, anybody could answer this.
Maybe like
We can have the question displayed. I think. Yeah. Like, can the team display the question, or this is the question from Dr.
It's
Shrikant?
from Dr. Shrikant. Yeah, it's from Dr. Shrikant.
I think, I think, yeah, this is the one. Question to the panel.
maybe I can try to take this question up. So
Yes, sir.
there is
Dr. Medhi, sir. Yeah. Yeah, can you minimize the questions, please? Yeah, Medhi, sir.
I think I already said that whatever data is existing, if you look at that animal data also, when you compare with chloroquine and hydroxychloroquine, so marginally hydroxychloroquine has much better efficacy. And with the clinical case also, if you see that the number of studies, it shows that hydroxychloroquine maybe it is better. That is the reason. But at the same time, it is like it is kind of investigational, and it's time to time it might varies also. Today, based on this limited evidence, you can say that.
I would like to add to this actually. So, if you look at the PK profile of this drug, like this drug is concentrated in the lung tissue, and like at least one PBPK model showed like after 5 days of therapy, like the drug level on day 10, that is 5 days after stopping like hydroxychloroquine, there is sufficient concentration in the lung tissue, which is much more than the concentration needed to inhibit the virus. There is no definite modeling evidence to even to say like following one single dose, the concentration in lung will be much higher. But what we can infer from this data is like, because when I look into the data individually, even it like it's only slightly like 2 micromoles less than the concentration on day 5. So if I can going to extrapolate based on the concentration seen on day 1, you can say at least till day 7, the concentration in the lung will be much higher than the concentration required to inhibit the virus. And the concentration ratio they are giving is like at least in the fold of like more than 20 times. So that might be one rationale on giving like why this drug can be used as an once weekly therapy as a prophylaxis. So we have pharmacokinetics or the drug concentration, but the biggest unanswered question is like whether this modeling data will actually translate to clinical evidence. Because we know like modeling information, we take lots of assumption, they don't always translate to clinical parlance. That is one question, and the next question obviously is like whether hydroxychloroquine actually has an antiviral efficacy. Unless we answer these two questions, uh, there is no definite evidence for the once weekly prophylaxis, but what I understand is it's better than doing nothing. And the way the recommendation is given by ICMR is only for high risk people, like who are at a very high risk of contracting the disease. And in this scenario, we have at least some preliminary evidence to say like this drug can be used. So one way of thinking is why not use that information? Maybe we don't have a definite answer, but the harm of
I,
using, yeah, yes, sir, please, sir.
I think one of the very important thing probably which is required for the consideration of prophylaxis in case of hydroxychloroquine is that there is a definite evidence that this is very good antiviral actually drug, and as he's telling that the concentration builds up in lungs, which is one of the main organ affected. I think one of the very, very important thing for considering hydroxychloroquine, there is a large number of actually data is available as far as safety is concerned because it is used for almost 30 to 40 years for the management of various other conditions. So we have got enough data as far as the safety is concerned, pharmacodynamic, pharmacokinetic is there. Hence, probably using hydroxychloroquine in prophylaxis may not be that bad as compared to some other drugs where the safety data is lacking. So probably the amount of safety data, dosage, everything which is available with hydroxychloroquine, that may be one of the reasons to consider it as a prophylaxis.
Okay.
I think some of the point as a pharmacologist, I already said that when you say that compared to another drug, same class of drug, what you do is you see that how much it is actually in the tissue level, like microference, or you want in the severe cases in the lung cases. So already been mentioned that when you look at the PKPD data compared to chloroquine, hydroxychloroquine, the concentration in the lung tissue is much better, at least on daily sleep. Okay. Second thing is what dose, whatever the dose you are giving, you act as an antiviral. We have an in vitro data, and also when you compare the chloroquine, it got a more, higher dose. And also when you look at compare the ADL profile with hydroxychloroquine and the chloroquine, so this is much favorable. So that is the reason. These are some
Okay.
of the scientific, data with a limited, time and limited evidence.
Fine, sir. Fine. Thank you. So let us have the next question, team. Again, Dr. Grammol to Dr. Bikash, in one of the media diabetes, it was, sorry, media debates, it was mentioned that hydroxychloroquine been management for diabetes. I think Sir has answered the same question. during his seminar. I think we're going to skip it because of the time issue. Next question, please. Yeah, Gramol, again, the answer for this ACE and ARB has been answered by Dr. Arasan. So we're going to skip it again. Next, please. So we have multiple questions coming from Docplexus and the IMPA's Academy Facebook page also. So the team is marking it when doing very well. Dr. Sangeeta Sukumaran, can you throw some light on potential of convalescence plasma therapy in COVID patients? Anyone? Shubhra, your voice is not audible.
So yeah, so there is a trial. It's under research stage. There's a clinical trial on by the US government now. The FDA has started this. Too early days, but there is no definitive role which is proven. It's an ongoing clinical trial in the United States.
Okay. Anyone else? Okay, so we can move to the next question. What's the role of favipiravir? I think this is all experiment. I think,
As I told you that there are, if you go and see the various database, you'll find there are number of drugs, especially in the category of antiviral. There are anecdotal reports. So still, we cannot say that this is what is exactly the role, because people are trying different antiviral drugs to see whether there is efficacy. So presently, we cannot answer that what is the role of particular antiviral drug till we get a very solid data from very good clinical trial.
I think my suggestion will be that when you select an antiviral, please look at some of the standard treatment guidelines, what it is recommended based on the evidence. Otherwise, you'll end up with using all the antivirals and
right.
Right.
Okay. So next question, please. Yeah, most important thing, role of anticoagulation in the hospitalized patient. So along with any COVID-19 medications, drug interactions. Can Shubhro take the question?
Yeah, I think it's a very good question. It's a great question. Especially in patients who are going to be in the ICU, they are immobilized patients. They are going to be ventilated. So they would be treated as any ventilated immobile patients. And definitely there is a role of anticoagulants, especially I would say heparin, because our low molecular weight heparin, no guidelines now mention that there is any clinically important drug interactions between the drugs like hydroxychloroquine or I would say azithromycin. So definitely there is an important role. As for steroids, I think the next
I
question.
already mentioned that definitely there is a clear-cut indication from WHO and CDC that one should not use steroid in management of normal coronary infection, except they are telling if there is a severe exacerbation of the pulmonary problem, and they are clearly telling that it should be used only under the guidance of supervision of a clinician. So there are clear indications that one should not use glucocorticoids in the management of coronavirus infection.
Thank you, sir. Yeah. Next question, please. So we're going to give, I think as an answer, so second grammar question has been repeated. Next question, please. Is hydroxychloroquine safe in patients, a person with PVCs, a premature ventricular complex? Anyone? Damodaran, can you tell?
Probably again take it up. So for prophylaxis, again it's like kind of an individual question, like.
No, but he's asking about whether very specifically, like he's asking whether like it's safe in PVC again.
Like if hydroxychloroquine used to be used for prophylaxis. Again, like it is to be like kind of done only in kind of extreme situations. For treatment, if it is under medical supervision.
As far I know, actually, one of the better marker for using that is actually the QT interval, and there are guidelines. They have mentioned that if you are, especially patient those having any cardiac problem, it is necessary that one has to determine the QT interval, and there's a definite guideline that if QT interval is more than 450 millisecond, one should be careful. So I don't think there is very specific, but all definitely the cardiac patient, it is mandatory that the QT interval has to be recorded before actually giving these drugs, because they are all known to produce prolongation of QT interval and can lead to various types of cardiac arrhythmia. So it is necessary.
Yeah.
I already mentioned that. Just keep up this, just remember that is there any cardiovascular problem, G6PD, and the children 15 years, less than 15 years. So if you generalize, just make it a point that if you ask the question about, because we do not have a monitoring mechanism, because otherwise you are continuously monitoring changes different. So it's better to avoid that.
Okay, sir. Thank you.
Agree. I think also Dr. Natesh, please send, I would say a very strong message. This is not for masses. Hydroxychloroquine is not for masses, but for very selective classes. This message should be very, very clear here, because people are buying, rampant people are buying. So the drug is not for mass utilization.
Correct.
Thanks, Dr. Shukra.
Absolutely.
Yeah. So now, next question, please. Again, same repetition. Like next question, please. Next question. Importance of ECMO in COVID-19 cases. So this is like very specific thing for cardiology, I think, but this is not due to any of the drugs.
It's not a pharmacology question. We
Yeah,
are not
that is
being-
It is a critical care specialist question.
Specific
So
question,
I think,
yeah.
but
I think we
then
can reserve the question.
yeah, whatever
Please.
limited knowledge I have, I can tell you that this is also in exploratory stage, investigational stage. So if you look at the WHO guidelines, nowhere ECMO role has been mentioned.
Okay. Yeah, so we have one very specific question for Dr. Arasan, sir. Dr. A.C. Jeshudas is asking, are there any approved clinical trials going on anywhere globally at this crucial time towards the therapeutic aspects of COVID-19? I'm going to repeat the question once again, sir.
Yeah.
The main question is from Dr. Jeshudas Prabhakaran. Are there any approved clinical trials going on anywhere globally at this crucial time towards the therapeutic approaches of COVID-19? The question will be displayed on the screen now.
I think the answer is plenty available in clinicaltrials.gov, right? There are quite a bit of studies that are getting approved.
I think what we can do it. See the Chinese registry, different registry. Just go to. You can compile all that. But you please refer it to Solidarity Trial of the WHO.
I think actually this can be answered that if you go to the website of WHO or clinical trial directory, you will definitely find, as I told you, that I know that very recently a trial has been initiated by US about enrolling 1,000 patients. So if you go to the website, you will definitely find out the various clinical trial which has been proposed or approved.
I'm sure for remdesivir, the study has started. The approval has come for that.
Yeah,
so,
and they have already recommended the actually recruitment of 1,000 patients, and they have given all clear guidelines and what type of criteria. Everything has been given in detail by that particular sponsor, which is now starting the trial in even Asian country.
Yeah, Professor Jesudas knows it. That's why he's asking all these questions.
Right.
Thank you. So next question, please. How long it may take to develop a vaccine? I think we can differ into two ways, whether like in a critical phase or a non-critical phase. Anyone? During this time, how long it will take to develop a vaccine?
I think it's very speculative question. People are working on it, and we don't know. We can't answer questions like that. So let's wait. Let's wait until end of April to have some lead products that are coming out from this whole thing, right? So it's too very early to say and speculate anything based on what is happening now. So we will pass this question.
Okay, sir. Thank you.
Presently,
So,
only the one clinical trial very recently started in Seattle, USA, with the vaccine. But as we know that any vaccine development takes time because the development and then safety analysis, everything required. But I think in the fast track mode, definitely we can expect that if really the vaccine is working very well preclinically and safety, and I already told that there are four questions one has to consider and develop. I don't think less than 12 months will be required to develop any clinically useful vaccine.
thank you, sir. So, 12 months time. Okay. And next question for Dr. MUR Naidu, sir. Which drugs are safer and preferred for an immunocompromised patient with COVID-19 infection?
Yeah, as I told you that this definitely says we don't have very clear cut, but definitely it has been shown as per the usage is concerned. Like we have got lot of data with the hydroxychloroquine, other antiviral drugs or other antibiotics which are recommended. We don't have any safety data in immunocompromised people. So I think the only drug which has seems to be very good safety data in immunocompromised the individual because these drugs are already used in other conditions like rheumatoid arthritis or SLE. I think except hydroxychloroquine, I don't think any other drug has got data to be used very safely.
Okay, sir. Thank you. Yeah. So, next question for Bikash, sir. Can we have antiviral activity of like of the drug chloroquine at the dose less than 750? So, what about the toxic profile? Please, sir.
So that is what I said that if you give a more dose, that then the toxicity profile will be more. So you have to see that what drug you are using, is it dose dependent? So if it is particular dose, it is worked as an antiviral, then you have to give a higher dose. And which will create a problem that which will also attract the more ADA. So comparatively, if you have a safer one with the lower dose, you have antiviral properties. So that is why hydroxychloroquine is used.
Okay, sir. Thank you. Yeah. Next question. Anything? Both hydroxychloroquine as well as azithromycin claim to be effective in COVID-19 and tend to increase PD interval. I think like we have like already answered it. Dr. Damodaran has answered it, right? So can we
Yes, it's
skip the
answered
question?
and we agree
Yeah,
to this.
we can skip the question. Yeah. Next question, please. This is very critical. Or asymptomatic coronavirus cases threat to others? This is a general question and is not with the with the current our webinar.
Ye-
So like
Yes,
anyone taking this? Anyone taking this,
Yes,
or can we skip it?
let's pass.
absolutely, they are threat to others, and that is the reason the concept of lockdown and being at home. That is the reason that for 21 days our government has asked to be inside our homes, unless until necessary. Please don't go out of home, and
And
that is the
Pratyush,
reason. That is the reason we have to be at home, and asymptomatic carriers, they can spread it in geometric progression to our population. So definitely it's a threat.
so it is like it is variable, but till 14 days or some people till 28 days. One has to be careful.
Okay. Thank you, sir. Next question. I think we can skip this question because we have answered this previously. Next one, please. Vijay, heparin can be useful not just from the perspective of preventing venous thromboembolism, but also from coagulopathy or DIC, and is recommended by WHO. I think this question is incomplete. I don't know what is intended to ask, right? The question is incomplete. So
I think this was with respect to prophylaxis. I think he wanted to ask about prophylaxis, that whether heparin could be used. So that's one of the recommended in patients with severe.
I think there
In,
are one in silico study have been published. Maybe he is referring to that. There is an in silico study has been published referring to heparin.
favoring heparin or against it, sir?
No, there is an in silico study. It is in online. You can download that.
no,
Okay.
it is in support. It is in support. What Dr. Natesh? It is in support. So
It is in support of.
what Dr. Vijay is saying is that not only acts against preventing VTE but also coagulopathy and DIC. But whatever it might be the reason, in severe COVID-19 patient, prophylaxis against VTE has to be given, and preferred is of course heparin.
Yeah, Vijay, what Vijay Talla says is right. So we agree with him. Yeah, we move on.
Okay,
Let's
yeah.
next question. We
Next
agree with
question,
him.
please. Why morbidity and mortality seem less in pediatric COVID-19 patients compared to adult? I think again this is a very non-specific question because we can skip this off now. Yeah, next question, please. Are there any clinical trials in India for COVID-19 currently? Do you have anything, sir?
So one can see the CTRI over a period of time. We'll get in detail. And of course, there are a number of people they have filed an application. So you can see number of trials, but it should be uniformity should be there with the market sample. So we have a
Yeah,
limited time.
I think last 5 days back, CDSUO has sent a note that if anyone has a proposal, they can submit. So there must be quite a lot of proposals coming in.
Yeah,
So
it is from
few,
it is from it is from the funding agency like GST, Birate. There are a lot of advertisements. So you'll get a lot of applications.
Okay, okay, sir. Yeah. Next question. So do you have a question? I think all the questions are out.
It's been a very long.
Yeah, I think so we are done with all the questions. So thanks all the speakers and the panelists like over here and all our viewers who have been very what can I say, interested to ask more questions. And also I'm very thankful for the Docplexus team who have agreed for our request to conduct this online webinar. I think this will be very useful, and I personally thank all the speakers for devoting the time like amid these tough things. So thank you one and all. I think it's been
Thank you.
so it has been a great time for everyone. Thanks.
Thank you, Natesh. Thank you, Natesh, for
Thank you.
arranging such
Thank you,
a
Natesh.
nice
Thank you,
thing.
IMPA.
And
Thank you.
really, it is one of the very good initiative, especially when actually we are all facing a very serious issue. And I think this is something a very good effort done by our organization, and I congratulate you for actually doing that one.
Thank you, sir. Thanks for with all support. So it's very helpful
Thank
for me
you.
to do this. Thank you, sir. Thank you,
Thank
sir.
you all.
Namaskar.
Thank you, Docplexus. Thank you
Namaskar.
very
Thank
much.
you.
Namaskar. No shake hand, please.
No seconds, please. Thank you.
Right.
Thank you.
Thank you.